One of the fundamental purposes of having an ICU is to be able to closely monitor patients who either are or are at risk for deteriorating quickly, and then to have the experience, resources, and ability to intervene quick. One staple of critical care is the monitoring and management of our patients' ability to breathe, and therefore we need to talk about respiratory failure. Alright you guys, welcome back to another video lesson from ICU Advantage. My name is Eddie Watson, and my goal is to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. I truly hope that I'm able to do just that, and if I am, I do invite you to subscribe to the channel down below. When you do, make sure you hit that bell icon and select all notifications so you never miss out when I release a new lesson. As always, the notes for this lesson as well as all the previous videos are available exclusively to the YouTube and Patreon members. You can find links to join both of those down in the lesson description below. Also, don't forget to head over to icuadvantage.com or follow that link down in the lesson description to take a quiz on this lesson, test your knowledge while also being entered into a weekly gift card. As well as don't forget that you can help support this channel through the purchase of an ICU Advantage sticker. Again, those are found at the website icuadvantage.com/support, link down in the description. So probably one of the most common reasons that a patient can end up in the ICU is because of some problem with their breathing. These problems can develop slowly and then eventually decompensate, or they can come on suddenly requiring rapid intervention. It can be the primary problem or secondary to other issues that are going on. That said, this is something that you will come across frequently, and it is important to have a good understanding of what's involved in this process. So let's start off and begin talking about what exactly is respiratory failure. Well, essentially, as its name suggests, that this is when our patient's respiratory system is failing to maintain its proper functioning. Ultimately, this means a failure of gas exchange, so either oxygen, CO2, or both. We can have abnormalities in gas exchange and respiratory function, but with respiratory failure, we've reached the point where the normal cellular function is at risk or compromised. If you do want a review of the respiratory system and gas exchange, I'm going to link to that lesson up above that I've previously covered all that. But when it comes to classifying our respiratory failure, we can do this in a few different ways. So first we have something that we call type 1 respiratory failure, and this is essentially our hypoxemic respiratory failure. Here, as the name suggests, that this is an impairment of oxygen in the blood, and we're typically going to define this as having a PaO2 less than 60 millimeters of mercury. Essentially, we don't have enough oxygen in the blood to properly perfuse tissue. Then we have what we call type 2 respiratory failure, and this is going to be our hypercapnic respiratory failure. So here we have an impairment of CO2 in the blood, and this is usually defined as a PaCO2 greater than 50 millimeters of mercury, as well as having a pH of less than 7.30. So this is a case of a buildup of CO2 and consequentially altering our patient's pH as a result. The reason for also evaluating the pH is that, especially with CO2, but also to some degree with our oxygen, that our target of normal can really vary based on the patient and the disease and the disorder that they may have going on. Kind of our classic great example of this would be a COPD patient who lives with an elevated CO2, but this is compensated with a normal pH. Now, we can also have something that we refer to as a mixed respiratory failure, and here we have a combination of both an impairment of oxygen and CO2. Now, also, based on the onset, duration, and the course, we can either classify our respiratory failure as acute, chronic, or acute on chronic. And the complications of respiratory failure are really varied, but often a result of the impaired gas exchange on various organs, and the mortality is often a result of multi-organ failure. So now let's talk about some of the causes of respiratory failure. And there are in fact many abnormalities that can lead to respiratory failure for our patient. These conditions may be pulmonary related or as a result of extrapulmonary conditions that can have an impact on gas exchange. It's really helpful if we think of 4 broad categories based on pathophysiology when we classify these causes. So the first one that I want to talk about is going to be impaired ventilation or hypoventilation. So ventilation, as we know, is the process of moving air into and out of the lungs and really ultimately the alveoli, delivering that oxygen and removing CO2. this requires physical movement of air driven by muscle contraction. And thus, any impairment here can lead to retention of CO2 due to not being able to clear it away, as well as hypoxemia by not providing enough oxygen. Some of the abnormalities that we can come across that are going to have an impact and lead to this hypoventilation can also be categorized themselves. First, if we kind of look at some of our neurological depression, and this could be the result of medications or drug overdoses, such as our CNS depressants. So here, think your narcotics and sedatives, etc., as well as anesthesia can also have this effect. And then also something like head injuries or strokes, anything that leads to elevated ICP in our patient. Then we can bunch a few more of these abnormalities together into our nerve impairment. And so here, first off, we have something like a spinal cord injury. And typically we're really concerned about the C4 level and above, as this is where the phrenic nerve is primarily innervated from. That said, we can have some respiratory impairment at a little bit lower levels, especially if we have some edema and swelling that kind of works its way up the spinal cord. But then we can also have just direct nerve damage. So here again, think the phrenic nerve, the vagus nerve, something that would have an impact on our patient's ability to breathe. We also have inflammation as well as diseases, and these here think of things like Guillain-Barré, myasthenia gravis, ALS, etc. And then even just neuromuscular blocking agents are obviously going to have an effect on this. We can also see hypoventilation result from fatigue of our patient's respiratory muscles, really from excessive use, as well as they can have chest wall injury, and then finally atrophy can also have an impact. Now from there, our next classification is going to be impaired gas exchange. And our gas exchange is really dependent on the proper functioning of that alveolar capillary membrane. If there's any impairment of this, then oxygen and CO2 are not going to be able to move across there freely or really even at all, thus impacting the ability to exchange these gases. And so real quickly, here's just a quick example of we've got our alveoli here, and then here we have the capillary where our blood comes in, and then our membrane existing right here where our gas exchange is going to take place. And so ultimately this impairment of gas exchange can really be the result of a few different things. We can have direct damage to this membrane itself. We can also have a collection of fluid in the alveoli, preventing gases from coming down here and exchanging across that membrane. We can also have collection of fluid in the interstitial space between the alveoli and the capillary, again creating bigger distances and impairing that gas exchange, or through the collapse of the alveoli itself. So in each of these situations here, we're effectively perfusing alveoli that cannot exchange gases, and this creates something that we call a pulmonary shunt, which is going to allow deoxygenated blood to reach the left side of the heart and then eventually go on to the rest of the body. Now, some examples of abnormalities that can ultimately impact the gas exchange are going to be things like inhalation of toxic gases or gastric contents, pneumonia, sepsis, ARDS, pulmonary edema, and this can be either cardiogenic or non-cardiogenic, a pneumothorax, pleural effusion, and atelectasis. Each of these is going to have that effect on the gas exchange by either directly damaging that membrane, causing fluid to collect inside of the alveoli, in between the alveoli and the capillary, or just by completely closing off that alveoli, making none of that gas exchange possible. All right, the next classification that we have is going to be our airway obstruction. So here we have an obstruction of airflow through the airways, really preventing flow into the lungs and then leading to hypoventilation of the alveoli. So some abnormalities that can obstruct the airway are going to be things like impacts to the wall of the airway. So here is an example of our normal airway, and then we can have things that can cause thickening of that airway. So think of edema and fibrosis, where that thickening is going to decrease the size of that airway. Or we can also have something like constriction, where it's also going to decrease the size of the airway, and here think your asthma and COPD. We can also have blockage of this inner airway. So here think of some sort of foreign body that gets lodged in there. Perhaps they have a buildup of excessive secretions or fluid in here. Any of these that are going to take up some of the space in the lumen of that airway. And then lastly, we can have just compression of the airway itself. So this can be a result of thoracic tumors that are pushing in on the airways. If you have enlarged lymph nodes or interstitial edema, any of these that are going to push in from the outside, closing down the size of that airway. All of these cases, though, share in common that there's going to be less availability of air to move through those airways, leading to that hypoventilation. And then finally, our last category is going to be our ventilation-perfusion mismatch, or our VQ mismatch. And so for proper gas exchange to take place, we must have the proper balance of ventilation, which is V, of air to and from the alveoli, and proper perfusion, Q, of blood to the capillary. So it's that balance of ventilation and perfusion so that we have enough ventilation going to areas that are being perfused, and vice versa, enough perfusion going to areas that are properly ventilated. So this brings me up to a couple terms that you've probably heard before, but I do want to explain them here, and that is the shunt versus dead space. So first I'm going to talk about our pulmonary shunt, and this is essentially where we have good perfusion without ventilation of the alveoli. So here we've got our alveoli, we've got our capillary coming through, we've got good perfusion of blood coming across this capillary, but because of something going on, and it could be one of many different reasons, we are not getting any ventilation to the alveoli, and this blood is just passing right by without being involved in any gas exchange. So we already just talked about some of the causes of this when we were talking about the impaired gas exchange and to some degree potentially with the airway obstruction, but this can also include physiologic issues such as pulmonary arteriovenous fistulas, as well as something like an intracardiac shunt, a right to left shunt. Now for our dead space, and here I'm specifically talking about our physiologic dead space, that this is where we have good ventilation to the alveoli without the perfusion. So just as a quick differentiation, we do have our anatomical dead space, and this would be, just as a very easy example, think of your trachea. So we have good ventilation of that area, but obviously there's no gas exchange, there's no perfusion to that area, so this is an anatomical dead space. We expect that dead space to be there. A physiologic dead space is one that there is not good perfusion there, but we would normally expect there to be. So here again, we've got our alveoli, and here is our capillary, but at this point we have good ventilation coming to this alveoli, but we just don't have enough or even any perfusion coming to this capillary. Some of the potential impairments of perfusion that we see would include things like shock. So here think we've got decreased flow of blood in general to the lungs. We can also have things like a pulmonary embolus or a PE, or microvascular clotting, where now we're blocking blood flow to that capillary via a clot. But we can also have things like emphysema, COPD, and asthma. And here we can have airway limitation. So not being able to move air back out, causing it to be trapped inside and hyper expanding the lungs and the alveoli, or due to a loss of elasticity, also leading to enlarged alveoli. And so in these cases here, while we have an enlarged alveoli with more ventilation taking place, the capillaries themselves are not actually getting any bigger. So we actually have more surface area of the alveoli with the same amount of capillary. So ultimately we end up perfusing less area that's ventilated. So those are the big causes, the different things that could be going on that really ultimately are leading to a difference in gas exchange that should normally be taking place. So now let's actually talk about the presentation that we're going to see with these patients, and let's start off with some of the signs and symptoms. So it's going to be really important to recognize these signs and symptoms, especially early on, so that we're able to intervene as soon as possible to try and prevent complete compromise. Now the signs and symptoms will often be dependent on the type of respiratory failure that's present. So we can see things like dyspnea or tachypnea, so difficulty breathing or rapid breathing. If they're making use of those accessory muscles, if they're diaphoretic, they can be restless, irritable, they can be confused or somnolent. All of this can lead to increased anxiety for the patient. You can also see pallor and cyanosis. This may lead to tachycardia and different arrhythmias. The patient may also be hypertensive. They could have a headache. You notice behavioral changes, really an altered level of consciousness or even coma, abnormal breath sounds, so crackling and wheezing, and then really just symptoms of any underlying disease as well, so our fever, cough, sputum production, chest pain, potentially hypotension if it's like a PE, etc. And then along with those signs and symptoms, there are a few things that we can use to either help diagnose respiratory failure or to help to diagnose those underlying causes. And really, the first and foremost gold standard is going to be our arterial blood gas, or our ABG. And the big things that we're looking at here are a PaO2 that's less than 60, a PaCO2 that's greater than 50, a pH that's less than 7.30, or a oxygen saturation less than 90. And then, like I said, we do have some other tests that you can expect, which are really going to be used to help to diagnose the underlying cause of the respiratory failure. But these are going to be things like our chest x-ray, getting an echo, ECG, doing a bronchoscopy, getting our cultures, so this is sputum, blood, and urine, and then different labs such as CBC, electrolytes, and lactate. And then finally, real quickly, I do want to cover the basic principles of management when it comes to respiratory failure. And really, our management of respiratory failure is going to be based on supportive measures and then treatment of that underlying issue. And so when it comes to our supportive measures, what we're talking about is really supporting oxygenation and ventilation. So many of the causes of respiratory failure are treatable, but will require aggressive support of oxygenation and ventilation to really allow time for the underlying problem to resolve. These supportive measures are not going to fix the underlying problem, but really buy time to identify them and then fix them. So we need to ensure proper oxygenation. Again, our goal here is a PaO2 greater than 60 and/or an oxygen saturation greater than 90. And using a pulse ox for continued monitoring is definitely going to be sufficient. Like I said, we also need to improve our patient's ventilation, and so here our goal is a PaCO2 less than 50, as well as having a pH that's greater than 7.30. And so first off, we have some non-invasive support that's available to us. So this is going to include things like basic oxygen supplementation, so regular nasal cannula, turning up the flow on there. You can do your different masks. If you really need a high concentration of oxygen, then we can use the non-rebreather mask. We can also use high-flow nasal cannula, or we can also do things like CPAP and BiPAP. And ultimately, our patient's condition and their deterioration is really going to dictate if non-invasive options are going to be available to us. Now, from there, we also have our intubation and then mechanical ventilation. And so the treatment may require better airway management, aka intubation, in order to provide proper ventilation, aka mechanical ventilation, and then ultimately the correction of those blood gases. So just some basic indications that we're looking at on whether or not we may need to progress to mechanical ventilation would include things like apnea with our patient and really respiratory arrest. If they're tachypnic, so if they're a respiratory rate greater than 30, especially if they're sustaining that respiratory rate, if they've got an altered level of consciousness, if you're really seeing respiratory muscle fatigue and beginning to see the patient, as we really refer to it, as tuckering out or tiring out. If they've got hemodynamic instability, that this can also be an indication. If they have refractory hypoxemia, despite the non-invasive support that we've tried, as well as refractory hypercapnia, and especially if we have a pH now that's less than 7.25. All of these would be our indications that our patient probably needs to be intubated and we need to control their breathing better with the vent. Some of the goals of this ventilatory support are going to be the correction of hypoxemia, and we're going to do this by controlling our FiO2 and using PEEP and other pressure strategies, correction of the respiratory acidosis, and this is really controlling the minute ventilation. So here, think your tidal volume multiplied by your respiratory rate. And then really kind of a big one that we don't think about is going to be resting of those ventilatory muscles. So really allowing the patient to relax and rest and let us do the work for them. And then sometimes even despite mechanical ventilation, that we may also need to add additional strategies in there. And these would be things like proning, using pulmonary vasodilators, or potentially something like ECMO. And then from there, once we have the patient stabilized and supported, then we really need to look to correcting those underlying problems. And this is really going to vary based on the evaluation of the causes and ultimately what the problem is, but we really want to be doing this as soon as possible once the appropriate support is in place. Alright, so that was our review of respiratory failure. Covered a lot of good information here. Like I said, this is something that you guys are going to come across all the time in the ICU, so it's really important that you guys do have a good understanding of what's going on with this, some of those underlying issues and causes that lead to this, as well as some of the expected interventions and what we're going to do for our patient. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.